Can I introduce Dr. David Paynton, who is the National Clinical Lead at the Centre for Commissioning of the RCGP, is going to talk about Francis and the impact it should have on CCGs. David?
Thank you. Good afternoon, everybody. Nice to see so many people here. This is a really exciting talk all about the Francis report. Before I start, and before we start playing around with the vote meters and the delegate response meters, or what are they called, can I just ask for a show of hands as to who has actually read the Francis report? About a third. That's good. So my first question, which I wanted, and let's see if the technology works. Oops, that's me. I am, as was mentioned, a practicing GP in a clinical area where 80% of the population don't have English as their first language. And I'm also working not only for the Royal College GPs, but in my own area as a clinical locality lead, representing 13 practices in the CCG. So the first question I really wanted to ask was how many people here think that the Francis report is relevant to primary care, both as commissioners and as providers of care? There's no right or wrong answer, but I'd just like to get a feel of how many people actually think this is relevant to them. So if you could press someone's got a hand up, but let's see if the technology works. Could you press your vote meters, just answering yes or no as to whether you think this is relevant? Yes, no, or don't know. Count. Do you think primary care as commissioners and providers are central to ensuring mid-staffs doesn't happen again? Yes or no? 10 seconds. Can we move on and see what... Excellent. Brilliant. So I'm already talking to a converted audience. Just a reminder of the NHS Architecture. I'm sure you've seen it again. But the important message about this is just to remind everyone that the cord between central government and what we do on the ground has been cut. Some people would like to mend that cord, but I don't think we ever will. So in many ways, and in all ways, it really is down to us now. So moving on, this is a very quick slide to illustrate some of the complexities of the world we're in at the moment, which is designed to show that as clinical commissioning groups, in the past we were accountable one way to the SHA, and now we're accountable three ways: to NHS England, to the GP practices, but also to the Health and Wellbeing Board, representing the local population. And of course this has led to quite a lot of confusion about lines of accountability and coherence in terms of what we do. So my next question was about fragmentation. And do you think at the moment, thinking of your local system, do you think your local system, bearing in mind what I've just said about the CCG having to face three ways, is more fragmented, less fragmented, or much the same? If you could just press on your vote meters. Yeah, that I think is pretty well what a lot of people would say. I'd be interested to know some of the 14% of people who felt that it was less fragmented, but I suspect most people would say, looking at their system, it's more chaotic now than it ever has been. So for me, it's about the CCG setting the scene as co-leaders with the local authority, getting the accountability right, getting the membership right, establishing the fellowship as well as the leadership, but above all, establishing a grip on your local system. Now, in terms of, and this is all building up to what Francis is talking us about, it wants us to think about, in terms of your local system again, it's always difficult when you're looking inwards, when you're looking outwards from the CCG to the local practices, or whether you're looking from the practices perspective inwards to the CCG. But do you think in your area that whatever the Constitution says, that practices are more involved than with the PCT, less involved than with the PCT, or much the same? And there's no right or wrong answer, but just to get a feel of what people actually think on the ground. So if you could press your vote meters. More involved than with the PCT. That's really good news. It's great to see that. It may be a selected audience, but it's good to see that sort of figure coming about. Why is it all important? Because of the challenges we face. Sorry, going back. Oh. Sorry, it comes of trying to not being able to look at the presentation. So let's go back. Yes, that's fine. So this is a statement about, this is where we start to look at the Francis report. And Francis was very clear that the mid-staffs was a failure of commissioners as well as the hospital itself. The failures of commissioners to take a grip. The failures of commissioners to establish the local culture, to focus on activity, not on outcomes, to hit the targets but miss the point, an over-reliance on providers saying everything's fine. So what I'd like to know from you, from your experience and your understanding of Francis, when you look at Francis's analysis of the failures in mid-staffs, do you agree, from your own experience, that it was essentially a failure of commissioners? Agree, disagree, or no strong thoughts? So if we could just move to the answers. That's an interesting one. And I think 1/3 agree that it was a failure of commissioners primarily, and about half think it wasn't. So we'll obviously want to explore that in a bit more depth. My own view is that if clinical commissioners are going to be successful, they have to establish a grip on their local system. And if their local system fails, or parts of it fail, that will be seen as a failure of commissioners as well as a failure of providers. But the responsibility of that failure will sit on the commissioners, not on the providers. So I want to move on to talking a little bit about the system we're going to have to work in at the moment. I don't know how many people have seen these slides, which look at the rise of multimorbidities and complexity in the population. This doesn't work, but if you look at the top left, looking at the numbers of people with no long-term conditions and the number of people with 1, 2, 3, 4, you start to get an understanding of the rise in multimorbidities and the challenges we face in addressing that. And if you look at the slide on the bottom left, you see that the rise in admissions goes up depending on the number of people with long-term conditions. So as the population ages and as the curve shifts to the left, you can see the inexorable rise in the pressure on the NHS to admit patients and deal with the problems. And in a sense, this has been going on for the last 10 years. But under Labour, we had huge injections of extra cash going into the NHS. We had 5 to 8% growth year on year. We absorbed all the problems of multimorbidities because we had extra money in the system. By the time we get to 2009 with the banking crisis, we see that money drying up. And as a consequence, if your hospital was on black alert this winter, it was not because they're not doing their job, but probably a rise in the incidence of multimorbidities in the context of no extra money. Traditional NHS inflation has been 5% year on year, and we've been funded for that up to 2009, but now the money has stopped. And that's the situation we're going to have to deal with. And we have to start thinking in terms of how we respond to the Francis report in this context, the rising increase in the ageing population, the rising tide of multimorbidities, the increase in complexity in a time when there's no extra money in the system. And CCGs are expected to pick all this up. And into this mix, we've also got the role of competition and cooperation. And I don't know how many people have seen this slide. I'd be interested, has anyone seen this slide? Just anyone put their hands up if they have seen it? Not many. This is a DH slide, which is designed to show how in CCGs we're expected to approach the competition and cooperation agenda, how we're expected to make our own decisions about whether we continue with, we move down the road of AQP, or whether we put a service out to tender or no competition. But however you look at it, there is pressure now to externalise the market. The NHS is to some extent going to be externalised. And if any of you are sad enough to want to read the Monitor consultation document, which is now out, on how they're going to approach this, you will start to get a feel of what might happen. A lot will still depend on whether Monitor want to apply a light touch or a hard touch on this. But at the end of the day, we are going to see more providers coming into the market and more externalisation of the market. And of course, that leads to more pressures in terms of the need to get on top of what providers are doing to ensure Francis doesn't happen again. So, could mid-staffs happen again as the NHS externalises the market? And I'd like you to think about your own system and ask a few questions of it. Firstly, in your own system, do organisations or professionals put themselves before the system? In other words, are they thinking about how we deal with this and not too worried about the effect on the rest of the system? Do we see silo mentality occurring in our system, in our local system, in the clinical commissioning group? Do we in our own area allow concealment to take place? And do we condone poor performance rather than challenge providers in this time of austerity? As the money gets tighter and tighter, as the NHS is externalised, do we think mid-staffs could happen again? Because I would argue that if any of these things apply in our own system, then possibly mid-staffs could happen again. So I'm going to ask a difficult question, which is a binary question, which doesn't give you the chance of saying don't know. Do you think any of the above, could apply in your own system? And if you could just go to the vote meters and give a response, we'll get a feel as to whether you think it's possible that mid-staffs could happen again. So if we move on, yes, I think that's the reality of it. 80% of us think there is a possibility. Not inevitable, but there is a risk. So as a consequence of that, we need to start thinking about how do we prepare and how do we make sure that we don't fall into that trap. Because at the end of the day, it's on our heads if our local hospital or provider or community service or we have a Winterbourne in our area, the responsibility will fall down to the clinical commissioners. So what does Francis have to say about commissioning? Well, he does talk about getting the right culture. He does talk about being very clear about what our population needs. Commissioners, not the provider, should decide what needs to be provided. Do we think that happens? In some cases, yes. In many cases, no. Underpinned by contractual standards, not led by contracting. Management of a system by contract never works, but at least underpinned by contracts. So, and he makes it very clear when you read the executive summary that responsibility for driving improvements in the quality of services should rest with the commissioners, which comes back to the question I asked first of all. Do we have a responsibility to ensure Francis never happens again, or mid-staffs never happens again? But everyone will say, well, yeah, but it's all about the money, stupid. And yes, money is tight, and it will get tighter and tighter. But there are some success stories, I would argue, from primary care. And one of the best examples is how we tackled all the issues around prescribing. Yes, there were issues about drugs coming off patent. There were issues about the price in the market dropping. But actually, prescribing wasn't all about cost. It was about building quality right into the heart of what we did and developing incentive schemes and incentives which encourage quality first, keeping within cost second. So the fact is, despite the fact that money is tight, I would argue that in primary care we have led some of the way on how we address some of these issues, despite the money not always being available in the way we'd like it to be. So, moving on, hopefully, got 10 minutes. What does this mean for CCGs? And this is really some statements that I put down as a way of generating some questions and answers. And we'll go back to one last question at the end, and then we'll probably have a Q&A session. So from my point of view, the CCG, if we're going to prevent Francis amid staffs happening again, or a Francis report being written on our area or a provider in our area, it's absolutely essential that primary care and the member practices commitment is there. And the question for me is how many practices, when you ask them, still talk about the CCG rather than our CCG. I think we've won the battle when practices start talking about our CCG, not the CCG. And do we dare ask? Another question. But also important to build on our professional values as general practitioners. Francis makes it very clear, and I don't know how many people have read this statement in the report. Out of interest, how many people have seen this statement? Just put your hands up if you've seen the statement. So about 20%. The GP's duty to a patient does not end with a referral to hospital, does not end when you press the choose and book button or you send the ambulance or whatever you do. Our responsibility does not end there, and our responsibility continues irrespective of whether the patient is being temporarily looked after by someone else. And therefore, if we're going to think about our CCG rather than the CCG, we've also got to start building up some of the soft intelligence which practices will know about far better than any contract manager about what's really happening in our system, because we hear it day in, day out. We hear it when patients come and say they had a good service or it was absolutely awful. They were left on a trolley for 8 hours in A&E. Now, not all experiences are bad, and we need to capture the good ones as well as the bad ones. But it's that soft intelligence, because I suspect in mid-staffs, GPs knew what was going on well before the commissioners did, but just weren't bringing all the data together in order to inform the commissioners. So what we've done in our own CCG is to start building in processes of getting that soft intelligence from practices back to the CCG. So the CCG knows quickly what's actually going on in the system. Well, why end there? Start looking at outcomes from our own practice data on what's happening to our registered list, and using prescribing as an example to develop quality premiums which build in expected outcomes within the resources that's available. And lastly, to make sure that we have an open relationship with our public and our local population. Because if, as I would argue, that commissioning was a failure in mid-staffs, one of the things they failed to do was to get a grip on their local system. And one of the best ways of getting an understanding of what's happening to your local system is to talk to your patients who've gone through it. And who are the people who know best about that patient experience? It's probably the GP and the community nurse and the practice nurse. So I would argue very strongly that we all have a responsibility not only to take the mid-staff's experience seriously, but also to build in the culture and the processes in with our own CCG to make sure we're picking up the information well before it starts appearing on any performance report. So with that in mind, I'd like to ask one last question, which was the question I asked first, which was, And I think probably the vast majority will still say yes. Do you still think primary care as commissioners and providers, and probably think about our role as providers as well as commissioners, are central to ensuring mid-staffs never happens again? And perhaps you could answer this not from our role as commissioners, but also thinking about as our role as providers and our responsibility to the individual patient and the registered list that we're responsible for. %95%. Thank you very much. Very gratifying to see that result.
Thank you, David. We've got a few minutes, and David can take some questions. If you put your hand up and wave madly, because it's difficult to see over here, please, and the roving mic will come to you. Okay? It's not working. Hang on.
Chris Watson, team leader with HealthWatch Nottinghamshire. I've gone to a lot of seminars today, a lot of discussion. HealthWatch hasn't been mentioned, but it's going to be key in this process to stop another mid-staffs, another Winterbourne happening, because the intelligence, the soft intelligence that we gather will be useful and will be very, very integral to stopping these things happening, because we are independent and people will talk to us and tell us things that they won't say to their own GPs, health professionals, because they are still frightened that they won't get the care they want, or they'll be treated badly if they complain. So they'll come to us. So CCGs, GPs need to be including HealthWatch in everything they do to make sure that they're gathering all the information.
I agree. It's working.
No, take mine.
I agree with that, and I think what's important is there's a partnership. You're right, there are some patients who have an awful experience but just don't want to tell their GP about it. Many of them do, but then say, don't want to make a fuss, doctor, please don't take it anywhere else. So I think getting that partnership is important, but the important aspect of that is it's got to work locally. It's one thing to be saying that in a meeting like this today, it's another thing to get that really working in your own area.
Okay, any more questions?
Yeah.
The mic's coming. Is yours working now? Try that.
I'll try it.
I don't think it is.
I'm Dr. Bose from Tarak CCG. Considering the prescribing constraints, and also considering that 37% of the population above the age of 55 have dysphagia and cannot take tablets. Now, how are we going to address that budget deficit? Because if we take an example of simvastatin, it's £1.20 for 28 tablets, but £160 for the liquid preparation, and that is only valid for 15 days.
Again, I think this is where local relationships have got to come in, because obviously prescribing patterns have got to be developed using your own medicines managers. But there's a much bigger issue for me around the increase in multimorbidities and comorbidities, which is how do we really introduce programs around self-management and care planning and proactive care planning, which focuses on the needs of the patient rather than always following nice guidelines for the 7 different conditions that everyone has. When I look at some of the patients I look after on 15 different drugs, I have to say, are we doing them very much good by giving them 15 different products? We have no idea what they do to each other. So I think one of the challenges in dealing with the increase in multimorbidities, and this is relevant to Francis, because if we don't manage it, what we'll see is the queues outside A&E getting longer and longer and longer. And whether we like it or not, we'll see more risk of mid-staffs happening just because staff are burnt out. We have to find another way of supporting patients in the community. And of course, in the community, Francis it was mainly about hospitals, Francis, when he looked at it, but actually many of the risks take place in the community, in our own care homes, patients requiring continuing care, the most vulnerable, the weak, people who are at risk. We all have a responsibility to find other ways of looking after them other than just sending them to A&E, which is what I'm afraid still does happen a lot in most systems.
We're running out of time. I'd just like to ask David, do you see any cause for optimism in the new system?
Yes, I do. I see huge grounds for optimism, but I think it's going to be patchy and variable, and it depends on the area and the leadership in the area. And it's not just about talking about the leaders of the CCG, it's whether we all as a profession recognise that whether we think it's right or wrong, and there were lots of mixed opinions about the health reform bill, it is law, and we have a responsibility to make it work. And I was listening to the previous discussion about do we have a responsibility to develop primary care? Yes, we do, because who else is going to do it other than ourselves? So, yes, depending on which side of the bed I get out in the morning, I feel optimistic or pessimistic. But actually, what I answer when people ask me this is, well, at the end of the day, it's down to us now, and I think as a profession we can rise to the challenge.
Thank you very much, David.